Okay, thank you, everyone. This is our special segment. I'm joined by Dr. Barry Duncan. And Dr. Duncan, I was wondering if you could start just by introducing yourself.
Sure. First of all, thanks a lot for having me. Just very excited to talk about stuff I'm really passionate about. So great to be here. I'm a clinical psychologist by training, and I've been interested in how to develop myself as a therapist, as well as how to privilege the consumer, the client, the patient's point of view in all services that they receive. And that served as the impetus for the co-development of some very simple, straightforward measures that we developed. And then I developed the clinical process of using those, which has kind of evolved into what's called in the psychotherapy literature routine outcome monitoring, but in the medical literature it's typically called measurement-based care. And I developed one of the two evidence-based practice measurement-based cares in the world, the other being the OQ45, and ours is called PCOMS, the Partners for Change Outcome Management System. So I'm the developer of the clinical process of that, and I'm also CEO of the web application of that evidence-based practice, which is called Better Outcomes Now. And I invite the listener to check out the website. There's 250 free resources about how to improve yourself on that website.
Awesome. We'll make sure to plug that link into the show notes to make it easy for everyone to access as well. So the reason why you're on the podcast this month is because you guys had some new, you and your collaborators had some new research that was published in Family Systems and Health. And so we wanted to have you come on and share some of that information with us about this work that you're doing and, what you're finding lately. Could you tell us a little bit more about that?
Sure. And this is very exciting at so many different levels. First of all, Dr. Brian DeSantis is somebody I went to graduate school with, and we have been friends ever since. And I don't know if you know this, but Brian was involved in the very early integrated care sites in the Air Force. So he's been a part of integrated care his entire career. And so he always wanted to collaborate with me. And he's also been a PCOMS enthusiast and used it in his own work for many years. He always wanted to do an RCT in integrated care sites. And our progression is, we've demonstrated improved outcomes and reduced dropouts in individual and couple with addiction, with mental health clients. And so we have all these RCTs. This is our 9th RCT, but we really wanted to establish it in the demanding workflow environment of integrated care with embedded behavioral health providers, in a primary care setting. And so that was our dream. And Brian and I started talking about it in 2015. It takes a long time to get this stuff together.
It does.
And so, we pulled off this delightful study in 3 different integrated care sites in Colorado and got just astounding results given the workflow demands of those that work in integrated care settings.
Yeah, I love that you were able to demonstrate it because, as you're talking about in just your description so far, there's 2 different language systems. And, we're talking about medicine versus talking about more, traditional mental health settings. And being able to show the applicability and the results across those different time settings, different trainings, different patient populations, a lot of times, really must be a big deal for considering the generalizability of your work.
Absolutely. And of course, we never know. I'm confident, given what we've shown so far, that it would be effective, but it's a very different context in the workflow demands. It's very fast paced. It's very group therapy oriented typically. And so there are some real differences. And so I was a little bit worried about the workflow. I was a little bit worried about the length of time because we generally know it takes about 4 sessions to realize a feedback effect. And just so that folks know what we're talking about here, it's 2 4-item scales that give feedback to both the patient and the provider about whether the client's benefiting from the service so that treatment can be altered if it's not. And so integrating that into the workflow, you have your warm handoffs, you have your docs just saying, I want you to see this person, you have them popping positive on the PHQ-9. You have all these different routes into it. So managing all that was, what we were wondering about. And of course, we found this great applicability in that it doubled overall outcomes, 40% more clinically significant change, 30% less dropouts, 22% more attendance. So, those are about the same effects we find in traditional behavioral health settings. They were able to transfer to integrated care settings.
That's amazing. And just such a important piece of that. We talk a lot too in CFHA about collaboration, not just between disciplines, but collaboration with the patient and engaging them in their care and really, empowering them to have more agency in giving that feedback and that communication to their providers. And it sounds like your tool really helps with that.
I'm glad you said that, because actually that was the raison d'etre of PCOMS. That's how it started, from my desire to do that in my practice. PCOMS is really different in that it came from clinical practice rather than research settings and academia and item analysis and all those things. It really came from a desire to privilege the client's point of view, the patient's point of view, and it does help engage people. And that may be where the feedback effect comes from, is that just engagement of the patient in the process, because anything that increases engagement tends to improve effectiveness, and that's true in medical care, mental health care as well.
Yeah. So were there any pearls that you guys found about workflow or about, how to really make this work in a medical setting that you could share with our listeners?
Sure. The major thing that we had to do was the routes to enable a person to get into the system and to have that easily done within the workflow of a behavioral health provider. So we had patients already in the system, ready to go, so that, when it was a kind of free-flowing situation where the doc said, hey, I'd like for you to talk to this person, not just, which was, generally not a surprise, but it's not a scheduled thing. Like if someone pops positive, the behavioral health provider knows this is the person I'm going to stick my nose in and have a conversation with. But when the doc says, no, I think this person would benefit, maybe they have a chronic medical condition that could improve with behavioral health intervention, or maybe the way that they're presenting themselves, even though they didn't pop positive, the doc thinks it would be useful for a behavioral health provider to talk. So we had to figure those things out and what would be the logistics of doing that. So the way we got our way around that is that we also gave the outcome rating scale, which is also a validated screener in primary care. Dr. DeSantis spearheaded a study to do that. And what we would do is when someone popped positive on either measure, and actually yours is a bit more sensitive because it's not just symptom related, then that would be the portal into the process. Still, the doc could say that they wanted to see someone else, wanted the behavioral health provider, but that was the main portal. So that kind of streamlined the portal, so there was less unexpected consults asked, so that helped a bit. And of course, the electronics, the digital system, makes everything easy. The behavioral health providers had iPads, and they would just give that to the client, and bang, they would take it. The measure takes 20 seconds to take. It immediately populates a graph so everybody knows whether or not the patient is benefiting or not. And so it expedites this kind of communication process with patients about their care. So that was the main thing. You just have to think through those aspects with people to make sure that the workflow demands don't make it be put to the side, which happens with implementation for sure.
Absolutely. Yeah. It seems like a lot of times RCTs get so standardized that sometimes we're not thinking as much about implementation or what is this going to look like in a real world application. So I love that you guys began with that, because we know that you can't do anything in integrated care without thinking about that implementation and sustainability. And I have a feeling a lot of our listeners' ears perked up when you said 20 seconds, because we know time is at an incredible premium in integrated care. And so that certainly is something that, you can't get much shorter than that.
That's exactly right. And that's another thing that Dr. DeSantis brought to the table. I mean, he's worked in these sites his whole career. He was supervising the practitioners that were part of the study. And so he was very, very cognizant of the workflow demands. And when we were designing the RCT, he was always kind of bringing that up, that this needs to replicate everyday practice as much as possible, not only for the generalizability and all that kind of stuff, but also just to help people implement it by having those things in mind. One quick thing I didn't mention was that the individual practitioner benefit doing PCOMs, of measuring outcomes, doing measurement-based care. And that is when you track your outcomes over time, you can, first of all, improve your effectiveness by identifying those patients who aren't benefiting, which gives you another opportunity to bring them on board. That in and of itself will boost your effectiveness. But then over time, you can use this as a career developmental path so that you can see how effective you are and then do things proactively to improve your effectiveness over time. And of course, if you gather data, and of course, the electronic systems do that and tell you how effective you are and even can make recommendations in the areas you might need to work more on to improve.
Yeah. Well, that is so fantastic. We're kind of coming to the end of our time, and I wonder if there's anything else that you want to share, and also where can people follow up to get more information? And we will link the specific RCT published data that you guys had in the show notes as well as your website. But anything else that you'd like to share with our listeners?
You can download the measures from the website for free. We used them paper and pencil a long time before they were electronics. Electronics add a nice part to it, but I did it for many years without the electronics. Paper and pencil forms, just download them and give it a try and see how your patients respond and see what you think of the whole thing.
I love that. Thank you so much. The proof is in the doing, right?
Okay.
Well, thank you so much for being here with us, and it was really nice to meet you and get to visit with you.
Nice to meet you as well. Thanks for the opportunity.